You are listening to the Horse Radio Network, part of the Equine Network family.
Hello and welcome to this episode of the Disease Du Jour podcast. I'm your host, Carly Sisson, and in this episode I spoke with Dr. Rebecca McOnie about equine castrations, including her preferred surgical techniques, anesthesia recommendations, safety considerations, and more. This episode of Disease Du Jour is brought to you by Equithrive. Dr. McOnie is an assistant professor in the section of large animal surgery at Cornell University's College of Veterinary Medicine. She earned her Doctor of Veterinary Medicine degree from the Western College of Veterinary Medicine in Saskatoon, Saskatchewan. After 4 years on the Canadian prairies, she was elated to spend a year in the heat working as a rotating equine intern at Arizona Equine outside of Phoenix, Arizona. She then moved to upstate New York, where she completed a 3-year residency in large animal surgery at Cornell University. Her areas of interest are equine sports medicine and surgery, as well as large animal emergency and critical care. Thank you, Dr. McOnie, for joining us.
No problem. Thank you so much for inviting me to be here with you today.
Yeah, I'm really excited to chat with you about castrations. To get us started, what are some of the key factors you evaluate before castrating a horse? And could you walk us through your pre-surgical exam process or any red flags that might indicate that you should proceed with caution?
Yeah, absolutely. I think the big question, so kind of to preface all of this, most of my work is in the hospital rather than out in the field day to day. So when we have horses come in for castration, usually the first big question is kind of, is this horse in good general systemic health? So are they well, and is it safe to anesthetize them for, or even do, say, a standing procedure and go ahead with the castration? So is it safe to do surgery on them? And that involves a full thorough physical exam, obviously with care to their normal vital parameters, and particularly whether or not they have a normal temperature. Making sure that they don't have a recent history of diarrhea or coughing. Airway problems, especially in younger horses, are very common. So making sure there's no snotty nose and that they're generally in good body condition as well. We make sure that their tetanus vaccination is up to date prior to operating them. And usually we're doing a little bit of mostly abbreviated preoperative blood work, so PCV total solids, just to check their hydration status before being anesthetized, make sure their red blood cell density is adequate. Depending on our initial physical exam findings, their history, we might be running a full CBC chem on them as well. And then obviously as part of the full physical exam, palpation of the scrotum and testicles is of significant importance for this. So we want to make sure that both testicles are in fact descended in the scrotum and that they palpate normally, that we're not finding any additional tissue, for example, intestines sitting within the scrotum. So certainly finding only one testicle on our physical exam is a bit of a red flag for us. Sometimes this happens with kind of previous attempts at castration on farm, sometimes hemi-castration, but sometimes these horses are cryptorchids that kind of instigates a little bit more evaluation of them. So trying to sort out, where is that other testicle? Is it inguinally retained or is it abdominally retained? And sorting that out can give us a better idea of how to proceed surgically. And sometimes it's just that they have a high flanker, so their testicle is sitting just outside of the inguinal ring, but it's a bit outside of reach and they need some sedation to be able to adequately palpate them. One of the other, this last red flags for me would be some breed predispositions. So there are some breeds like draft horses or standardbreds that are generally thought to have larger vaginal rings. And the vaginal ring is kind of the tissue that lines the inguinal canal and is the limiting factor for what tissue can go through the inguinal canal. So if that vaginal ring is enlarged, then those animals are at a higher chance potentially of having herniation, or if there's no closed skin, potentially evisceration associated with castration.
So is there an optimal age to castrate horses, and how do you approach castration in older stallions versus younger colts?
Yeah, most of the time we're aiming to castrate horses between about 6 months and 2 years of age. Frequently, that's driven by the convenience related to how these animals are housed and being able to put them out with fillies or mares. 6 months is kind of around that weaning time or just after weaning time. And early on, like that, the animals are at a generally smaller size that could make them a better candidate for an anesthetic procedure if you're choosing to do a castration under anesthesia. Sometimes castration is a little bit delayed when there's an inguinal cryptorchid testicle, so a retained testicle that's sitting in the inguinal canal. Some people elect to wait a little bit longer, to more like 1.5 to 2 years, to see if that testicle descends. But usually by 2 years, if there's no sign of that other testicle, it's not coming out.
Right.
In older horses, the major differences that I've encountered as far as castration are the extent of the blood supply associated with the testicles, which is pretty immense in older stallions, and then their potential for having a little bit more pain following castration. So usually the management in that case, the older stallions, we generally prefer to do a pretty controlled primary closure castration in an OR. That's kind of our ideal, what we're generally recommending. This allows us to have a little bit better control over potential bleeding, better cleanliness, and applying ligatures as well if those are needed. And then just making sure that we have adequate pain control on board for these horses kind of perioperatively as well.
Right. And then in a perfect world, is there an ideal time of year that you would castrate?
Yeah, I think it has a lot to do with where you live. So in most seasonal climates, I think fall is a pretty good time for castration. And usually foals are getting weaned or are weaned at that point. The bug population is getting under control as well as temperatures diminish, and it's generally not overly hot or overly cold. And especially if you're having to anesthetize the animal for the castration, there's no snow on the ground yet. So right. Usually fall is a pretty good bet.
This episode of Disease Du Jour is sponsored by Equithrive. Brought to you by Equithrive, the leaders in resveratrol science, Medicare is a new pelleted daily supplement offering metabolic support for easy keepers. Medicare is formulated by Pat Lawless, PhD, to support optimum carbohydrate and fat metabolism, healthy body weight, and appropriate insulin levels in horses, thanks to a proprietary combination of resveratrol, flavonoids, and amino acids. Learn more at www.equithrive.com. Well, speaking of anesthesia, what is your go-to protocol for this, and how do you prepare the horse and the environment for a safe procedure? I know that you're primarily working in the hospital, but maybe you have some tips for vets who are doing castrations in the field as well.
Yes, I am pretty lucky that I work in a hospital where the anesthesia service and my colleagues look after that side of things. They're generally running horses where the foal's on triple drip with oxygen supplementation in hospital. But I think a pretty standard dosing of xylazine and diazepam followed with ketamine, I think is generally a pretty safe bet. Certainly, as you're starting out and refining your dosing of those medications, having additional kind of top-ups or half top-ups available, or particularly spunky horses having a temporary catheter in place to be able to maintain anesthesia, depending on the kind of capability of your assistants as well. That can be a useful way of getting drugs into the horse very quickly. And then as far as the procedure, kind of generally the setup for that, making sure you're in an area, obviously, like very basic safety. I think as equine vets, sometimes we put ourselves out as sacrifices as far as safety, but trying to make sure that the environment is safe for the horse and for us as best as possible. most of the older stallions, if they are being castrated in the field, doing them in lateral with the leg. Usually in hospital, we have the leg elevated if we're doing them in lateral, but you can tie the leg forward up around the neck and chest. That can be a little tricky, certainly if the horse is trying to stand up early. It needs to be quick release for sure, but the smaller weanlings can be in dorsal and just steadied with shavings, bales, or straw bales to keep them positioned.
Well, I guess moving on now to the procedure itself, can you walk us through your typical approach to surgery? And do you have any techniques or tools or tricks that you found that makes the process a little bit easier?
Yeah, absolutely. I have done many different techniques for castration. I certainly prefer to have the animals anesthetized. I think with the population we end up seeing in hospital, that's usually the intention, is to have the older stallions in particular in the hospital on their backs to be able to have a very controlled castration environment. With standing castrations, the level of cleanliness can be a little bit more challenging to maintain, but certainly when there are contraindications for anesthesia, then we do prioritize doing a standing castration. When the animal is in dorsal for a primary closure castration, so for example, one of those older stallions, I generally do a Coomer type approach to the castration. So the surgical incisions are made essentially just axial to the inguinal ring, just axial to the inguinal crease, and about 5 to 8 centimeters, depending on the size of the testicles. Testicle gets pushed up to the skin, and you can incise over the skin, the sub-Q, and open the vaginal tunic. Bring out the testicle, and then I, especially with the older horses, generally double ligate the pampiniform plexus. And another indication of being spoiled, we have access to cautery in the hospital, so we're able to use the cautery instrument to transect across the pampiniform plexus, distal to the ligatures, across the mesorchium and the vas deferens, to really be very careful about any hemorrhage or preventing any hemorrhage there. In that case, we end up closing the vaginal tunic. So it's considered an open castration with primary closure of the skin. And most of the clinicians in our hospital use this technique for castration. We generally find that the limited dissection involved with that open approach helps to minimize the swelling postoperatively, and it's a pretty quick and easy access to that inguinal area as well. If we're doing a twist and tack type procedure, if we're doing a vaginal tunic ablation in the case where we're concerned about the diameter of the vaginal ring, particularly in those breeds like standardbreds. That Coomer approach is a fairly similar inguinal approach to what you might do for, say, an inguinal cryptorchid. At least the initial incision is in a similar location. And what else can I tell you about that? In the field, I guess one of the tips that I picked up from a mentor was, if you are dealing with an older stallion or one that has very developed testicles, doing a modified open approach where the cord and the tunic are emasculated separately. If you're having a lot of trouble getting the cord in a closed castration into the emasculator, you can do a modified open approach, separate out the cord and then the tunic, and emasculate them separately to make sure that the hemostasis is appropriate. And then I think the other main castration technique that we're using in hospital is cryptorchidectomy. And certainly for the testicles that are maintained in the inguinal canal, those can be quite straightforward to get to through just an open approach. But abdominally retained cryptorchid testicles can be very efficiently and safely removed using laparoscopy. So that can be done both standing and under general anesthesia, and usually just has to do with whether or not we want to leave the skin open when we castrate the contralateral testicle, or if there's an indication for doing a primary closure of the contralateral testicle.
So, how often do you encounter complications when performing castrations, and how do you manage these? Or are there any patients that are at a higher risk, or any situations that carry a higher risk?
Yeah, ultimately, complications are relatively low in occurrence for elective procedures like this one, where as long as the animal is healthy to begin with, we usually don't end up with significant complications. That being said, we don't want to underestimate the potential for complications. We often think of castration as something that we do very commonly, it's kind of routine, but certainly does have potential for complications. Likely the most common one that we see is surgical site swelling. So making sure that we adequately manage bleeding and ensure appropriate hemostasis during surgery is very important. Making sure there's adequate drainage if you're doing an approach where the skin will be left open, and then ensuring that the horses have adequate exercise post-operatively. So most people will prefer to, if they've left the skin open after castration in the field, ensure that the animal is really being actively moved around and has turnout in the days and weeks following castration. And even in the primary closure castrations that we do in hospital, although those animals are usually still rested for about 10 to 14 days, we encourage them to at least have some hand walking and they're not just sitting in the stall. The minor swelling that we can see, really, those are bleeders usually in the sub-Q or associated with the skin. The kind of worst case scenario as far as hemorrhage that can occur in these procedures is testicular artery hemorrhage. And in those cases, the cord and the testicular artery can pretty rapidly retract into the abdomen, or at least deep into the inguinal canal, and can cause substantial bleeding in that area and potentially hemoabdomen as well. That can be really difficult to manage in the field. And we have a really nice technique to manage that at a referral institution, kind of another shout out for minimally invasive surgery. What we've done in several cases is a standing laparoscopic approach. So after these horses have had their inguinal area or scrotal area just packed off, the animal's in adequate systemic health after this emergency in the field, they're shipped to a referral institution, and we're able to put a laparoscope in through a flank incision, a small flank incision and cannula, and then use a cautery instrument, the bipolar vessel sealing device, to go right across the abdominal components of the vasculature, including the testicular artery, and stop the bleeding that way. It also gives us a chance to assess how much, if any, bleeding has occurred into the abdomen. So we've had quite good success in that scenario when practitioners encountered this really emergent testicular artery hemorrhage in the field. The other complication that can certainly be encountered is infection. Usually we're administering perioperative antibiotics in these cases, even though they're done in a clean environment. Certainly in the field, the risk for potential infection, just based on the environment being a little bit less controlled, the wind and dust, and maybe horses having a challenging recovery from anesthesia as well. Those things can all contribute to contamination around the surgical site. And certainly if there's inadequate drainage from a surgical site that is being left open, that can compound the risk of infection developing. And unfortunately, we do occasionally see horses that develop a serous cord. So the cord stump that has been transected becomes infected, and that ascends, and it can at times, especially when it is not identified in a rapid manner, it can ascend up through the inguinal canal to the abdomen, and that becomes a little bit trickier to treat, but certainly one of the major potential complications down the road from castration.
How soon after castration would an infection typically appear?
Yeah, oftentimes, even within 5 to 10 days after castration, the consistency of the discharge from a site that is left open can start to change, and it might go from being a really thin, red serous discharge to thicker, more purulent looking sort of discharge. In our primary closure castrations, sometimes it's more 10 to 14 days before any sort of drainage is noted from those incisions. But in the primary closure castrations, there really shouldn't be any discharge after surgery. It should be pretty dry. Sometimes, though, if there isn't really obvious drainage, just because of the kind of dynamics of the incision, maybe not allowing that, it might be a couple of weeks before somebody notices the extent of swelling that has developed in that area. And those are the cases where you're more likely to have that ascending infection and the serous cord develop.
Okay. So I know we touched a little bit already on turnout following the procedure, but what is your standard approach to postoperative care, and how do you set owners up for success during the recovery period?
Yeah, so with the primary closure castrations, most of the time the horses are stall rested for about 10 to 14 days with light hand walking about 10 to 15 minutes a couple times a day. That seems to be pretty well tolerated, helps to minimize some of the swelling, but still protects the surgical closure site to some extent as well. I think importantly for the owners, or rather it is important for the owners to understand what they are monitoring for. So taking their horse's temperature regularly postoperatively, at least once, maybe ideally twice a day for up to a week after surgery. A fever can be certainly a red flag for some of these cases, and then making sure that they understand what to look for at that surgical incision site. So looking for the type and the consistency of discharge, looking for any increase in swelling at that site, and just being willing to be in touch with them or they with you to make sure that any concerns are addressed in a timely way. Certainly, as far as more serious complications with tissue herniation or evisceration, it's important that owners understand that that is a low occurrence type complication, but can be a dramatic and fatal complication, and should know to be looking for any sort of tissue protrusion from the surgical site.
Awesome. Well, as we wrap up today, do you have any other tips for making castration safer and smoother, either in the field or in the hospital setting?
I think overall, just being sure that these young horses that we're doing surgery on or anesthetizing really are starting in a good spot as far as being systemically healthy. It's a really good starting point to keep in mind. And apart from that, careful hemostasis and monitoring post-operatively.
Great. Well, thank you so much, Dr. McOnie, for joining us today. I really enjoyed having you on the podcast.
Yeah, no problem. Thank you so much for your time.
I'd like to say thank you again to Dr. McOnie for joining us, and thank you to Equithrive for supporting this episode. And as always, thank you to our listeners for tuning in to Disease Du Jour. If you have any questions or suggestions for the podcast, please send me an email at csisson@equinenetwork.com.